please.
Thank you, and thank you very much for the invitation. Whatever the disease is in which you have an interest, whether it's cancer or any other chronic disease, or whether the treatment in which you have an interest is alleviation of pain, improvement in adherence to medications, change in lifestyle, I think it's safe to say that our interventions, our non-pharmacologic interventions, are not well integrated into clinical practice. So the orbit model is answering a question of why is this, that they're not integrated into clinical practice. And our point of departure is that the orbit model says we must spend more time developing our interventions and pushing them toward the behavioral efficacy trial. Voila, voila, voila. To move forward on the top. Sorry. So you may be asking, well, why do we need a model? Why is it important to have a model? We have everything that we need already. And I have 3 reasons for that. The first reason is that we need a model that makes sense to the medical gatekeepers, because the patients we work with are seen primarily by people in clinical practice, by the physicians in clinical practice. Another reason for the model is that we must change the culture in behavioral interventions. We are fixed on one approach to testing interventions, and I think we need to expand that approach. And finally, we need to give our patients more choices. That right now they go into clinical practice and they are given drugs, even though behavioral treatments might dramatically improve outcomes. So let me focus on this a little bit. This is the process of drug development. For a drug to go to market, it should follow each of these phases that are agreed upon by everybody in the medical field. So there are preclinical phases where patients aren't utilized. It's in vivo or, in vitro or animal studies. It goes from there to phase 1, where the focus is on assessing toxicity of the drug. It moves on to a determination of biologic activity. In these different early phases, there is no control group in general. There's small subjects, small numbers of subjects, and there's a versatility of designs that are used. Finally, we go to the phase 3 efficacy trial, and this is the piece that is crucial for bringing the drug to the market. We have no similar process on the behavioral side, and we need to be able to have a process that is recognized on the medical side as something that is consistent with rigor. We also need to change the behavioral medicine culture. In behavioral treatments, we have essentially one design that we use regardless of the question that we're interested in. And the design is over here. We have accessible subjects. We randomize to a treatment or an attention control. In this kind of design, our focus is on the treatment. We want to control for nonspecific attention, despite the fact that many times our behavioral interventions include attention as one of their key components. In addition to that, when you focus on an attention control group, many times the attention control group is actually more active than we had expected it to be, which then reduces the chance that we can find an effect for our treatment. We need a culture change. We need to start looking at these designs that focus on not the treatment, but on the outcome, and start looking at other ways to consider control groups. How does this treatment improve what we're doing in clinical care. Therefore, an appropriate control group would be a usual care control group. We don't do that very often now in the behavioral side, and we need to change that culture. And then finally, we should give patients more choices. A patient who comes in with problems that are clearly a function of lifestyle, they're obese, they're sedentary, they have diets that are inconsistent with health. What happens to these patients? They go straight to drugs. So the more we can get efficacy trials, behavioral efficacy trials, incorporated into the literature, the more we give patients the choice to either choose to change their lifestyle or to choose to go on drug therapy. And our best estimates are that about 50% of our patients would prefer to explore lifestyle and how that can either augment their drug therapy or replace their drug therapy. Because of these concerns about inadequate attention to treatment development, we had a workshop several years ago in which there were 5 institutes from the National Institutes of Health represented, as well as 7 sites with investigators, all of whom shared an interest in behavioral intervention development. The orbit model has come from a synthesis of the wisdom that we discussed during the course of this conference. This is the orbit model. It is now published online in Health Psychology, so there is a paper that you can look at if you want to get more information about this. It doesn't focus on phase 3 efficacy or phase 4 effectiveness trials. This is in the realm of other areas of research. Our focus instead is on the early phases of treatment development, and it has a couple of key features. One is it encourages crosstalk between people developing behavioral interventions and basic behavioral and social sciences. Right now, these two groups do not communicate well. In addition to that, the orbit model encourages crosstalk between people who are in clinical practice, medical practitioners in clinical practice, and people who are developing behavioral interventions. And right now, that crosstalk does not happen very commonly as well. In addition to that, it is a progressive model that says at each stage of this model, different questions will be asked. Different questions are of interest, and therefore, different designs for how to answer these questions are needed. Finally, the orbit model has bidirectional arrows. And what this essentially means is a lot of times we do an intervention and it doesn't work. And then we go off and try a very different intervention. What we want to say in the orbit model is we should spend more time working with promising interventions. If it doesn't work at this phase, go back and reconsider what we decided to do in an earlier phase. So it's bidirectional, it's fluid, and it gives us the opportunity to tweak our interventions in the presence of results, which really doesn't exist now when we test only fixed protocols. So what I want to do this morning is I want to go through the basic elements of each one of these phases of the orbit model and really just tell you the key point within each one of these phases and encourage you, if you're interested, to read the paper to get more detail. Okay, so the first phase is crosstalk between the developers of behavioral interventions and people in clinical practice. So we're saying that if you really want to have an impact on the care of patients with chronic diseases, figure out what the problems are that the clinicians are facing. So here's a common problem. This is the algorithm that doctors use for management of blood pressure. Wherever you see yellow, here, 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 and here, the recommendation is to promote lifestyle changes. So in the area of blood pressure management, people need to lose weight, they need to limit their salt intake, and they need to manage their stress. right now, clinical practice goes directly to drugs, which are down here, because people believe lifestyle can't be changed. That's a significant clinical question that we on the behavioral side could answer. This is another significant clinical question. This is adherence to medications. These are patients who need medications to manage their cardiovascular disease. I think the thing that's most important here is that over 50% of the prescribed drugs are not taken as prescribed. And when we look at adherence to medication across a variety of different diseases, across a variety of different outcomes, the number hovers around 50%. 50% of our patients are not getting the drugs that are prescribed to them. That is a significant clinical problem. You can have the best drug in the world, but if the patient isn't taking it, it's not doing them very, very much good. And this is the kind of problem that behavioral interventions can help solve, because it's a behavioral problem. It's not a medical problem. So a significant question focuses on the disease. The disease affects many. The prevalence is high. It's increasing, or it's increasing in subgroups, or it's costly. And the current treatments that we have are not very effective, or there's poor adherence to them. Therefore, a novel treatment focusing on behavior might actually have a chance of having benefit. Okay, the second piece of the orbit model focuses on crosstalk between people who do basic behavioral and social sciences research and people who are developing interventions. And I want to give you an example of one of the areas that I think is most exciting in the behavioral intervention development world. And this is the beginning of crosstalk between applied behavioral sciences and neurosciences. So say we want to develop a weight loss intervention. What can the neuroscientists tell us about this? Well, one of the things that they have found doing CT scans of the brain is that impulsive eating is a limbic system function. And impulsive eating means I want to eat now, right now. Nothing is going to stop me from eating right now. It's a limbic system function that is triggered, and it demands immediate gratification. Alternatively, neuroscience has shown us that in the frontal cortex, issues associated with planning and decision-making and delay of gratification are all a function of what goes on in what we call the CEO of the brain. So when you think about it, you think, well, you know, my intervention to reduce weight would best be served if I can get the patient not to trigger their limbic system, but instead to do some advanced planning so that they avoid triggering the limbic system. So this intervention would be something that would be environmental restructuring, where we ask the patient to plan for exercise when he comes home from work. So the first thing he sees when he changes out of his work clothes is his exercise clothes. And then the other thing we would do is ask him to remove any triggers that are going to trigger the limbic system from the home. So that's our intervention, and it's elegant because it makes sense from what we understand in the area of neuroscience. So we have some basic behavioral science that supports the quality of this intervention. This piece of the orbit model is the very early phases of intervention development, and the basic principle here is when you start to develop an intervention, it will be a progressive process, but the very first piece is develop a plan. So what does this mean? It means before we do any studies at all, we have to have a roadmap for how we're going to judge success. And that roadmap will focus on a behavioral risk factor target. And the behavioral risk factor has to have an implication for a clinical event down the line, because we know we're angling toward a behavioral efficacy trial. We want to identify early on, from primarily epidemiologic studies, a clinically significant level of change needed to assess success. So what is a clinically significant level of change on the behavioral risk factor that we need to judge whether this intervention has been successful or not? And then other early phases of making a plan is how many components should this intervention have? Should it have just one? Should it have two? Should it have five? So the whole thing, and this is a crucial point, this is our plan. This is our roadmap. So before we collect any data, before we see any subjects, we've got a plan. And what this plan does is it identifies an hypothesized pathway by which we're going to go from our treatment to ultimately a clinical endpoint. So in this case, our ultimate clinical endpoint is weight. And we know we're trying to get about a 7% reduction in body weight, 7% or more, because we know clinical guidelines tell us that if you reduce weight by 7%, you can have a benefit on chronic disease outcomes. So we've got a goal here. We look at physical activity. This intervention is going to focus on physical activity. Our goal here is to get patients to be physically active at a level of about 150 minutes a week. So we know that because there are guidelines that exist in the area of physical activity that tell us if we achieve that level of physical activity, we can have a benefit on outcomes like weight. So now we know where we're going. We know the level of strength we have to have in our intervention. This intervention has got two components, and this piece tells us whether or not we were able to achieve change in the behavior of the patient with each of these two components. Now, why is that important? It's important because a lot of times our interventions fail. So we think we're going to go from here to here, but we're not able to achieve benefit on the targets of the intervention. In other cases, the intervention worked, we're able to achieve change in these targets, but it didn't translate into benefit on physical activity. Those two states of affairs are very different. In the first state of affairs, our intervention failed. In the second state of affairs, the intervention worked, but it didn't translate into the behavioral risk factor of interest. In other words, it was a failure of our hypothesis. So disentangling whether it's a failure of the intervention or a failure of the hypothesis is a crucial piece to work out in advance so we can ultimately evaluate the success and the reasons for success or lack thereof of our interventions as we move forward. This phase is a refinement phase, and most of the studies that we see in behavioral interventions focus on this phase. And this is where I say we in the behavioral side really need to expand the versatility of the designs we use. So some of the questions that would be of interest in this phase are, how many components do we need? Do we need just one component in this intervention? Do we need 5 components? If we think we need 5 components in the intervention, can we get away with only 2 and therefore increase the efficiency of the intervention without reducing the strength of the intervention? Other questions are, how much of this treatment do people need? Do they need a month? Do they need 6 months? Do they need to have the intervention go on for 1 year? Who is the right agent of change for this intervention? Can we do it as well with a smartphone as we can do it if we have patients looking at each other face-to-face and meeting in groups? So these are the kinds of questions that are directed toward this second phase of the orbit model. And just to give you a couple of examples of the versatility of designs that can be used in this phase, I show you a fractional factorial design. We're trying to determine here whether we need 2 components or whether we can get away with just 1 component. So in this kind of design, one group gets both components, one group gets one of the components, another group gets the other component, and a fourth group gets nothing. So this will help us determine whether or not we can get away with just one of these two components, which ultimately will save costs. Another example is what's called the adaptive design. And I think this is on the horizon of our behavioral interventions, because it says when we do an intervention, we know some people will respond and others will not respond. So once we see that a patient isn't responding, what's the next best treatment to do for them? So the non-response would then dictate a second treatment to try to up the intensity of the treatment and achieve benefit for these patients. So this design is saying here's treatment A. These people are early responders, so we just keep going as we were before. This group is a non-response group, so we're trying to determine whether or not for the non-responders we switch to a new treatment or we add to the existing treatment an additional treatment. So I think this is on the horizon because this is very similar to what they do in clinical practice in terms of drug titration. So you give a patient a drug, they're not doing well, they're not having the benefit that you expect, so you increase the dose. That's what this intervention is doing, but it's on the behavioral side. The next phase of the orbit model is the concept of a proof of concept study. Now, a proof of concept study is something that we don't see very often, but it's really a very quick and dirty, not very costly way to see, once we have our intervention together, does it have benefits that are at the level of clinical significance that we're seeking. So these designs are not randomized. They focus on a small number of subjects, and they just ask a simple question. Does this treatment, as I've got it developed today, produce a clinically significant benefit? So the structure is small n's, no control group, inexpensive, close surveillance by the investigator, no statistical inference. We're not dealing with statistics because we're not creating a statistical hypothesis. We're just trying to find whether or not this treatment has a benefit that is clinically significant and therefore merits further testing using a randomized design. Once we get to a randomized design, we increase the cost and we increase the complexity of what we're doing. Do we really want to do that before we have a clear idea about whether this intervention has merit, has any merit at all? That's the concept behind the proof of concept studies. And I'm just going to show you two examples from my own lab about how we did this. This is only 29 subjects. They all had the metabolic syndrome at baseline. We said, if we're going to take the time and effort to do this trial, it's a lifestyle change treatment, we will judge success based on whether these patients in our proof of concept study, half of them were able to have a remission on the metabolic syndrome. So the way we plot this is that this is the goal. We're looking for 50% of our patients to no longer have the metabolic syndrome. And we see that at the end of 6 months, we exceeded that goal. And during the maintenance phase that went on for 2 years, we hit or exceeded the goal. Now, what is the value of this? The value of this is that we put these data into grant proposals and tell the reviewers that this intervention has merit. And you can see that something is going on here. Now we need, as a next step, to randomize and see if this benefit is better than the passage of time alone or whatever the control group might be. But this is a green light that says something is going on here. We didn't spend much money to do this, but something is going on here and it merits more rigorous evaluation. And this is another example. There's only 4 patients in this study. This is a study of adherence to asthma medication. To have adequate adherence that has biologic effects, you have to take 70% of your asthma medications. So here's 70%, here's the cut point. We're working with very disadvantaged inner city teenagers who are very non-compliant to their medication. And as soon as we instituted this intervention, we're exceeding 70%, and we're exceeding 70% for the duration that the intervention is going on, which was 8 weeks. Again, this is not the definitive test of this intervention. It is a test that didn't take very much money to conduct, but it shows promise with this intervention that if we increased the sample size and increased the complexity of the design, we might have a shot at getting benefit. The final piece of the orbit model is pilot studies. And I think when we talk about pilot studies, we talk about them from a variety of different perspectives. There are many different kinds of pilot studies, but the two that are most common are ones that use a randomized design. We increase the sample size. We're looking for statistical significance between the treated and the control group. And we have a more challenge because we try to understand the diversity and response. But I think the other thing that is really important about pilot studies is this is an ideal time to assess the adequacy of our control group. And I think what we are moving toward now is this commitment to studying the control group in a fashion that's similar to studying the treatment group, so we can be sure that when we get into a randomized design, the control group behaves in the way we want it to. And behaving in the way we want it to means they're not dropping out differentially, and they're not changing on our primary outcome in ways that will dilute our treatment effect. So there are a number of papers that are coming out now that are directed toward the adequacy of the control group. But the one thing that I want to point out is the control group has to be consistent with the question you're asking. Sometimes you want to ask a question about the treatment. Does this treatment have benefit over non-specific attention? But other times you want to ask a question about the benefit of this treatment in clinical practice. That question would be, does this treatment improve outcomes in clinical practice over the standard treatment? So you can see that in that second example, the control group would be standard of care or optimal standard of care, or something that focuses on what's going on in clinical practice. Whereas the other question, the first question I posed about treatment, asks a question about what are the mechanisms of treatment. Right now, we need to start thinking about versatility of designs because our focus is on that first question. There's another kind of pilot study that is very different in nature from the one that I just described, and that's called a feasibility pilot study, and it is instituted just before you're ready to do a large-scale efficacy trial. And this kind of study is focused on the feasibility of the trial protocol. You want to see if you have many sites, if all of the sites can implement the protocol. You want to see how long it's going to take you to recruit patients for the trial. And you want to see how quickly patients drop out of the trial, how acceptable it is to them. And I think one of the things that this is an ideal time to do is to examine different approaches to recruitment. And we're very interested right now in the pros and cons of a hard sell. You really need to be in this trial. This is going to save your life. This is really exciting. This is the best thing we've had in a long time, versus putting people together in a small, putting potential recruits, potential subjects together in a small group setting and asking them to consider the pros and cons of going into the trial and taking the time to be a participant in the trial. And one would think that if we're only thinking about recruitment, let's do the hard sell. But if we're thinking that recruitment is linked to retention and retention is crucial in a clinical trial, then what we would want to do is screen out the people who are thinking, you know, now that I think about the reasons I don't want to participate, I really don't want to participate. You screen them out earlier so that you maximize the internal validity of your trial. In summary, the orbit model is asking investigators to spend more time developing your treatments, to be willing to accept null results, but not walk away from the treatment, to go back and say, now, what was it about this treatment that didn't work? Talking to patients, talking to people who are on the staff, trying to figure out how to tweak the trial. And people have talked about this approach as something you would do with your car. Your car doesn't work, so you pull up the hood and you go down and you try to tweak different things to make the car work. It's basically the same. The fluidity of the orbit model is the same. We want you to stick with the treatments for a longer period of time. We also want people in the behavioral world to push toward the efficacy trial, because conducting a behavioral efficacy trial in a rigorous way with a great deal of attention to intervention development is the language of medicine. And I think if we're going to do good for our patients, we have to be better at speaking the language of medicine. Thank you very much for your time.